All right, good morning, everybody. We're just having people joining us on the call, and so we're going to give it another minute or so to let everybody in, and then we'll get started. Okay, I think people are still coming in, but we're going to let them continue to flood in, and we'll get going. So my name is Nicole Cyberlick, and I am at the University of Michigan, and I have the pleasure to host today's 30-minute CMR Journal Club. So the topic of this session is going to be atrial imaging. So, usually, at least when I think of imaging the heart, we're typically looking at the ventricles. They're much thicker and just easier to measure. But there's been a lot of interest in atrial imaging and especially looking at atrial fibrosis. And so we have two papers today, one which talks more about the utility of measuring atrial fibrosis and how that correlates to atrial stiffness in patients with atrial fibrillation. This is a paper that will be presented by Dr. Dana Peters. And then we're going to move over to something that's a little bit more technical. So looking at a new technique to generate three-dimensional, high-resolution, dark blood, late enhancement images to evaluate the presence of atrial scar. And this paper will be presented by Dr. Dongyue C. So without further ado, I'm going to hand over to Dr. Dana Peters, who will be presenting our first paper. So Dana, there you go. Perfect. You can go ahead. There you go.
Oh, great. Can you see this on paper?
Yes, we can see it now.
So thank you for letting me present. This is a paper that was written by Jérôme Lamy, who isn't here, but he was the main author, and then it's a collaboration with cardiologists and a radiologist and electrophysiologist, and we also have a biomechanical modeler that was giving us some help with this paper. Atrial fibrillation is a very common disease, and what I was really interested in is the role of elevated cardiac pressure in causing atrial fibrillation and in causing left atrial remodeling. That's really important. And we know that elevated pressure should increase LA volumes. That's why LA volume is this huge biomarker that it is. And so we think pressure in the LA can lead to stretch, and that can lead to development of atrial fibrosis. So there's the other important thing to realize is that people with atrial fibrillation often are associated with diseases of elevated cardiac pressure. For example, heart failure patients, hypertrophic cardiomyopathy patients, people with obstructive sleep apnea all develop AF, and those are also people who are known to have elevated pressure. So there's this so what we really wanted to look at is in AF patients is this triad of strain, pressure, and stiffness, which we were going to measure with left atrial fibrosis imaging to try to understand remodeling. And this is like a very simple model that that we use, which is that strain, if you think of a sphere, which has a thickness of B, and it has a stiffness that we call E, then you can say that strain is related to pressure, of course, but modulated by its thickness and its stiffness, which is E. So what we thought is, okay, we can measure strain, pressure, and stiffness using MRI, not using MRI. We can measure strain and stiffness using MRI, and we'll see if and using some invasive pressure measurements, can we see this relationship? So this is like why the reason this equation is why in echocardiography they have this stiffness index, which is basically pressure over strain. So they call that, this is a metric, it's called pressure over LA reservoir strain, and it's used in echocardiography, except they don't have pressure, so they use E over E prime for pressure. And so we thought that we could use, we would be able to measure stiffness using 3D high resolution LateGadolinium enhancement, and we can measure left atrial strain using feature tracking. So what's important is that in non-AF subjects, there's so many papers that say that strain is related to pressure. So that there's lots of papers on this. And so the question is, in AF patients, where you have very large volumes, where you have remodeled left atriums, is this still true? So this is really important, because if you could measure, somehow if you could say that strain is an indicator of pressure, that would be a huge thing. But so we wanted to really look at that in AF patients. So we hypothesized that there was going to be a pressure strain relationship, but it may be modulated in AF cohort because they have such a range of volumes and because they have fibrosis, and looking like just as it's described in equation 1. And we wanted to look at the relationship between LA strain with pressure in this AF cohort. And then I guess the other thing that we just were also looking at is, you know, how LA strain is unique compared to LA volume and ejection fraction. And because people talk about LA strain like it's different than LA volume, but of course it's very much related. So this is a study where we had 107 patients who had basically long axis cine and high resolution LGE acquisition, and they were going to go for a pulmonary vein ablation within a month. And at the time of the ablation, the pressure was measured directly by the electrophysiologist. We had to exclude some of the subjects, mainly because of foreshortened left atrial views, especially in the 2-chamber. And if you have a foreshortened left atrial view, you might as well just throw that data away, because you'll get completely wrong left atrial strains. And then some we had to exclude because of arrhythmia, where the images were just bad, and then also mitral regurgitation, which was extensive because that would affect the results a lot. So we had 67 patients, and 41 of them had 3D high resolution LGE. So this was all done on a 1.5 Tesla Siemens scanner. The cine obviously was BSFP, and this shows the acquisition parameters for the 3D LGE. This was pretty standard. It took 5 minutes total acquisition time, so including the navigator gating. And the resolution was 3 millimeter. This is the reconstructed resolution, 1.5 by 0.7 by 0.7, and the true resolution was about double that in every dimension. So we use CardioTrack for strain analysis, and we have an expert, Jérôme, is developed CardioTrack with the group at in Paris, and this is available if anyone's interested. You have to contact contact Jérôme or his group. So we were able to measure strain, and here you can see the definitions of strain: reservoir strain, conduit strain, active strain during the atrial kick. And then we also measured the times to peak reservoir strain, to the time of conduit strain, and we also measured the strain rates. So we measured, it was a comprehensive evaluation of left atrial strain, just basically global longitudinal strain. And I guess the one that turns out to be sort of interesting is this time to peak reservoir strain rate. So how long it takes, so like this time when the peak reservoir strain, what is that time period. And of course, reservoir strain is also always very important. So we always measured all the three left atrial volumes, the minimum, the maximum, and the pre-atrial kick volumes, and we measured each ejection fraction. All the variables were normalized to BSA, and we did all this analysis blinded to the other metrics. The LGE post-processing was performed just using manual segmentation of enhanced pixels using a patient-specific threshold. And so this just shows some examples where you can see like, it's, I'm not sure if it projects, but there's some slight enhancement, LateGadolinium enhancement in the atria of this patient, and you can see it segmented. And then in this patient, there's some slight enhancement. We quantified the extent of LGE, and we also normalized it by the left atrial myocardial volume. And so this has been at least tested for intra-observer variability and shown to be a very good reproducible approach for evaluating atrial LGE. So the pressure measurement was prior to the catheter ablation. So here we also measured, as I said, the stiffness index, which was the invasive LA pressure divided by the LA reservoir strain. And we also looked at different categories because the problem with atrial fibrillation patients is they're so heterogeneous. So we at least looked at people with lower left atrial volume versus higher left atrial volume. Here you can see that just some of the patients. So the patients were average 67 years old, mostly men. And we didn't have very high elevated pressure. So the mean pressure was 12 millimeters of mercury. So it wasn't very highly elevated pressures in this group. Some of the patients, you couldn't see the atrial kick, either it was not missing or it was fused. And most of the patients had elevated LA volumes. So here we're just showing like, something I guess you shouldn't do if you want to find significance, but we looked at everything. So I can show you the heat map. So we looked at every parameter, LGE, all the LA volumes, all the strains, strain rates, strain times. And you can see what we really cared about was pressure. And you can see that basically nothing correlates to pressure except LA volume, the maximum LA volume, and this reservoir strain rate time. And so those are the only two things, nothing else. And so this is not like a normal patient cohort. The normal patient cohort, they have found that LA reservoir strain correlates pretty strongly to pressure. So these are different patients, is what this is saying. And then I just wanted to point out LGE, which really is related to the stiffness index. So if you look at LGE, you can see that at my cursor, so stiffness index was strongly correlated to LGE. So LGE, which is really a measure of stiffness, which is the kind of the thing that I thought was possible in this group, and definitely you can see strongly here. And then the other thing that I thought was really important is just to realize that all of these things are the same in some way, like strains and volumes, they're all really strongly correlated even in this AF cohort, or maybe especially because they have such a wide range of volumes. But like, for example, LA ejection fraction and LA reservoir strain are correlated with the R value of 95.95. So that's high. So that's sort of what we found with this this heat map. So what was really important is atrial LGE was correlated to the volume strains and most strongly to stiffness index. we found, as I said, LA ejection fraction and LA reservoir strain are very closely related. We found that, so we used atrial fibrosis in milliliters and not atrial LGE in percent. And so I think I'll just, because I'm going too slowly, I will talk about the.
So Dana, I'm sorry to interrupt. In order to have time for questions, I'm just going to ask you to wrap it up as quickly as you can.
Okay, so this just shows an example of our data. And I will just show you the pressure. This is the LJ versus stiffness index correlation. It's not bad. And this is the pressure versus left atrial volume correlation. We didn't get many correlations with pressure. So that's all. Sorry to be slow.
No, it's all good. 10 minutes goes by very, very quickly. So thank you for this presentation. Are there questions from the group? Feel free to unmute yourself and just go ahead and ask your question or to put a question in the chat.
I see one on the foreshortened left atrial.
Yes. I was gonna bring that one up if no one else had a question right now. Go ahead, you can answer that one.
Just that, you know, like you'll see a left atrium that isn't actually the proper long axis view. And what happens is that you get this very high strain, and you can think, oh, this person has enormously high strain because the volume is changing dramatically between systole and diastole, and you have to delete, just throw it out.
So that was my question. I'm just starting out as a PhD student, so I'm a bit new to the terminology. So thank you for answering. I was just going to ask, what are the challenges with the imaging patients with atrial fibrillation in general? Shouldn't it be pretty difficult to get good CMR pictures in this cohort?
I think it's pretty difficult, but oftentimes they're not in AF at that time, it's paroxysmal. Or the other thing is for atrial LGE, I think that oftentimes the images are good quality even with arrhythmia, and it's because it's really depends on what the rhythm was, whether you can actually get a good null and how much arrhythmia artifact there is. But in our experience, definitely you can have good quality even with lots of arrhythmia.
All right, thank you very much.
Right. There's one question from Luke Hopman. So he asks for you to elaborate a little bit more on the patient-specific threshold that you used for the LALGE.
The thresholding is really a challenge, and so like people use different thresholds, and sometimes I feel like they use the wrong threshold. So what we do, which is very reasonable, and it turns out to be basically an image intensity ratio of about 1.4. But what we do is we say the valvular apparatus is collagenous. So we look at the valves, we see what the signal intensity of the valves are, and we use that as our thresholding. And I think that's fair, because that's like an internal reference. But it usually does turn out to be what people have suggested, about 1.4 for an image intensity ratio.
All right, perfect. There's a couple more questions in the chat, and so maybe Dana, if you could answer those separately, because we're going to move on to our second presentation so that we don't run out of time. So again, this paper is entitled Three-Dimensional High-Resolution Dark Blood LateGadolinium Enhancement Imaging for Improved Atrial Scar Evaluation, and it'll be presented by Dr. Dongyue.
Okay, thank you for the introduction. And can you see and hear my voice?
We can hear you, and now we can see the screen. Perfect.
Okay, perfect. Thank you. And I'm glad to be here to introduce my work during my PhD in Tsinghua University. And actually, this is actually focused more on technique development, which is developing 3D dimensional high resolution dark blood LGE imaging to improve the atrial scar detection. So first, I think maybe go quickly through the background. The previous study have indicated that the extent of atrial scar before and after the RF ablation is correlated with the recurrence of atrial fibrillation. Therefore, the atrial scar detection is important for pre-procedural decision-making and post-procedural prognosis. And conventionally, the electroanatomic mapping is can be used to identify the atrial scar through the electro measurement, but this is an invasive method and can potentially time-consuming. Alternatively, the MRI LGE imaging provided an non-invasive method. However, the detecting the atrial scar with the LG is challenging, mostly due to two factors. First is the tissue contrast. Actually, this can be very significantly depending on the different parameters such as the contrast agent dose and the imaging time since contrast agent injection and and also image resolution and field strength. So the dark blood ALG imaging proposed recently maybe have a stable and superior image contrast between scar and the myocardium and the blood pool. Other challenges for atrial scar quantification is because of the difficulty in segmentation of the atrial wall. Because of the complex anatomy structure of the atrium, especially surrounding the pulmonary veins and the thinness of the atrial wall that is close to the image resolution. So usually an additional bright blood imaging is required for with a separate scan to perform the atrial segmentation. So in this study, we developed dark blood PSIR image sequence that can acquire and co-register the 3D high-resolution dark blood and bright blood images to improve the atrial scar detection. So this is a flow chart of the participants. We have included 20 atrial fibrillation patients, and they have all went through an RF ablation, and the 16 patients have got the electroanatomic mapping for the reference of the atrial scar. And after 3 months, all the patients went through the CMR imaging, which including the protocols, including the conventional localization and cine images. And after 15 minutes of the contrast injection, the patient was scanned with the conventional PSIR image sequences and the proposed new PSIR image sequence. They have been divided into 2 groups randomly and with different scan orders. So the image sequences can be shown in this figure. And for the conventional PSIR sequence, this is performed with an inversion recovery preparation to acquire the first images, and the second images is used for the reference to correct the phase of the first inversion recovery prepared images. And for the proposed new PSIR sequence, we add an additional T2 preparation, and which is combined with the inversion recovery to get a dark blood LG images for the first image. And for the second image, we also applied an additional T2 preparation to improve the image contrast between the myocardium and the blood pool to get a bright blood image for the structural imaging. And for the image interpretation, we just measure the two, measure the signal to noise ratio and image contrast. So this is measured according to the ROI of the scar, blood pool, normal myocardium, as well as the background noise. And then we quantified the atrial scar area, and this procedure is shown in the supplemental figure. And yeah, sorry, can you see the figure now?
Yes.
Okay, so For the conventional PSR sequence, the atrial was segmented with additional scan of the bright blood imaging, and because of the two images was acquired separately, so additional registration was required to apply the segmented left atrial to the bright blood ALG images. And for the proposed PSR sequence, the two images was acquired simultaneously, and so that they are intrinsically co-registered. The left atrial segmentation result can be applied directly to the dark blood ALG images. And the second step is we rendered the left atrial surfaces with the images intensity, and then the 3D surface was imported into the control system, and the atrial scar area was segmented manually by the cardiologist. Okay, so let's go back to the main text. And we can see some of the results here. The first is a comparison of the image contrast. So the visual comparison it showed that the proposed sequence can improve the scar-to-blood contrast, which can provide a better delineation of the atrial scar area, which is not so certain in the conventional bright blood ALG images. And for the quantitative comparison, shows that for the first image, the blood signal was significantly decreased, so that the scar-to-blood contrast was significantly improved. And for the second image, the signal of the myocardium was significantly decreased, so that the blood to myocardium contrast was improved. And we also performed some comparison of the image contrast and the relationship of image contrast and the imaging time after contrast injection. Conventional PSR sequence showed a higher correlation. However, the new proposed sequence was less correlated to the image time after contrast injection. And the second is for the scar area quantification. So the visual inspection shows that the area with contrast enhancement in the PSR sequences is overlapped with the low voltage area in the electroanatomic mapping. However, there are some enhancement in the conventional PSR sequence that was not so consistent with the reference. And the quantitative comparison shows that the conventional PSR sequence have some significant difference compared with the electroanatomic mapping, while the new developed PSR sequence was not significantly different with the reference electroanatomic mapping. And the linear regression also showed a higher correlation between the scar area measured by the proposed PSR sequence and the reference electroanatomic mapping. So we can come into some discussion is that our study have showed consistent results that the scar-to-blood contrast of the conventional red blood PSR sequence was correlated with the delay time after contrast agent injection. This is not for the new developed PSR sequence, so that indicating a good potential for the clinical application with less dependency on the specific scan time. And as a result, the native scar area measured by the conventional PSR sequence was not so consistent with the electroanatomic mapping results. However, the new proposed PSR sequence provided a more stable contrast as well as a more accurate scar quantification result, with a stronger correlation to the electroanatomic mapping than the conventional sequence. So there are also some limitations, including some further optimization of the image sequence, such as the more motion compensation about the irregular breath pattern or the irregular heart rate, especially for the patients with atrial fibrillation. And some of the inflow artifacts maybe exist in the images. And the second is the atrial scar area in the MRI was manually defined, and some threshold-based method can be used to define the atrial area, scar area, but because of the different image contrast, it's a dark blood contrast, so maybe requires a further validation of this threshold-based method. Thirdly, that only participants in the sinus rhythm after the treatment was included, and maybe a source of bias and the image quality with patients with atrial fibrillation is not so confirmed. And finally, that we believe that histopathology analysis may be required in the future. And I think that's all. Thank you.
Great, thank you so much for this nice presentation of this paper. So there's a couple of questions in the chat that we'll tackle first. So the first question is from Luke Hopman. So he says that it's clear in the images there is an extensive inflow artifact in the superior right pulmonary vein. Is this affecting the detection of LALGE in that area? And do you have any ideas of how you can address this issue?
So yeah, we did notice some artifacts. First is that because the blood is so dark that the signal to noise ratio is not as good. And the second part is we got some inflow artifact from the pulmonary vein, as I mentioned in the limitation. So I think first we can do something like for advanced image reconstruction method to reduce the influence of the low SNR. And the second is that inflow artifact may be addressed by using a different motion compensation strategies, because most of the artifact was induced from the navigator excitation.
Great, so related to that question, did the T2 prep pulses, were those wideband pulses? This is from Dana Peters, where she says the off resonance of the lungs might be affecting the T2 prep in the pulmonary vein blood and causing some of these artifacts.
Yeah, I think so. Actually, we used adiabatic T2 preparation in this study, because this is performed at a 3T, which maybe I think using an adiabatic T2 preparation maybe have a better performance. And yes, I think the T2 preparation may be a factor that will maybe cause the inflow artifact.
All right, awesome. So we're going to wrap up this week's Journal Club. So thank you again, Dr. Peters and Dr. C, for your great presentations. I'm just going to hand off to Matthias very quickly to introduce the topic for the next month.
Yeah, could you please unshare your screen, Dongyue?
Okay, thank you.
Yeah. So I really enjoyed the papers today, well presented and very interesting. The important area of LA enhancement. I think this is clinically important. So in April, we will kind of also look at injury, but this time we walk to mostly the left ventricle. It will be about myocardial infarction, and there are two papers that I found really interesting, maybe a little bit provocative at times. Both are on infarct severity and outcomes. One is from Ivan Lechner, from the group of Sebastian Reinstadler on temporal trends in infarct severity outcomes in ST elevation MI. And the other one is a proposal of a new classification of infarcts based on the degree and the appearance of myocardial injury. So this is also about no reflow, and so interesting from a consensus team from Canada, and first author is Andreas Kumar. So they both have agreed to present on April 3rd, and I will be happy to welcome you there and wish you all the best from my end. Until then.
See you then. Have a great day, everybody.
Bye.
Bye.